Okay, so yeah, thanks very much for having me, Fiona. I've never spoken at a nurses conference before, so this is a first. As Fiona said, I'm a clinical lecturer and specialist in oral surgery at the University of Leeds and Leeds Teaching Hospitals. And obviously we would have potentially been in Birmingham today, which is kind of home territory as I did my training in Birmingham. So sadly we're not there, but anyway, that's sunny Leeds on a good day. And I'm going to talk to you today, if I can make my slides move, about venous cannulation, which I was a bit surprised as a topic. When Fiona asked me to speak, I thought, oh yeah, there's loads of oral surgery and implantology things I can talk about. And then she said, talk about venous cannulation. So it's obviously a topic in demand. So we'll talk about that, a little bit about blood. I don't want to be too dull on a Saturday morning and talk about too much pathophysiology, but I think it's important that you have an awareness of blood in the context I'm going to talk about, and then why we use venous cannulation in dentistry and oral surgery and where you fit into this. So I'm assuming everybody is from a nursing background as opposed to maybe hygiene and therapy. So that's where I've pitched it. As everybody has in these positions, lots of different hats. So from a venous cannulation point of view, it's a big part of my working week. So I'm an advanced life support instructor and provider for the Resource Council. I'm also, so interested in listening to Glenn, I'm an expert witness for the GDC as well. So I see a little bit of medical legal work. And I came across Fiona on the educational board at the Faculty of Dental Surgery at the College in Edinburgh, where I'm the educational advisor for oral surgery. So I have a bit of an insight into education and do a little bit of key opinion work for Action, who is a company you may have come across. So I use their piezo surgery quite a lot. But my main job is an academic oral surgeon at the University of Leeds. So we've got undergraduates, postgraduates, specialty trainees, and my week is really varied, from teaching, clinical work, and then I'm also doing a PhD. So that professor title that Fiona gave me, hopefully we'll get one day. And my working week is very variable. Clinically, anything from third molars, do a lot of sedation, both inhalation and intravenous sedation, bit of oral medicine, a lot of surgery, obviously, implants, bone grafting, that kind of thing. So lots of different things to see, and hopefully it'll be quite a light-hearted talk. So why cannulation? Why is it important to us, or why is it important in general? So cannulation is obviously putting a tube within a vessel, and that can be venous or arterial. I'm going to talk about venous cannulation today because arterial cannulation is not something that we use. We can give drugs through cannulas, we can take bloods, and we can take bloods to donate, and we can use it for monitoring. So the monitoring and the delivery of drugs, monitoring can be done through an arterial line. So you may, if you watch, I don't know, hospital or ER, things like that, you may hear somebody say, oh, they've got an A line in or a central line in. And that's where we've cannulated into an arterial line. And if you cannulate into an arterial line, you can measure the blood pressure as it is at that instant. And you can obviously also take samples so you can get blood gases from an arterial line. And delivery of drugs, you can also give through a central line, so it's in the central venous circulation. But for dentistry and oral surgery, it's really delivery of drugs and sampling of blood, and I'll talk to you about that. We obviously don't take blood for donation, but the blood sampling, patients we might see with oral medicine conditions, so we might want to do classically things like hematinics. You will have come across patients who are anticoagulated, who are warfarinized, so we need to take an INR for those patients before we treat them. And other patients that we might see preoperatively who've got symptoms or medical conditions that we need to have an idea of what's going on. So they may be anemic, they maybe have a platelet disorder, they might have query liver disease or liver problems, which might affect clotting, particularly for surgery. So it might be that preoperatively I say, actually, I could do the full blood count, a clotting screen, and hematinics, ferritin, B12, folate, that kind of thing. And obviously in INR, we used to do a lot of venous sampling for INRs, but nowadays this can be done as point of care testing. So it's a finger prick test and you get an instant result with your INR. So we've gone away a little bit from that, but certainly for blood sampling in the clinic, we can use those tests. And the big thing that I use blood sampling for nowadays is something called PRF, You may have heard of PRF or PRGF, which is platelet-rich fibre, and I'll talk about that in some detail because I think that's really where your role can be expanded as nurses. And delivery of drugs in oral surgery or dentistry really is conscious sedation, and that's single drug use, which is midazolam. I've put steroids in grey because occasionally, if I'm doing a big case, I might give them some intravenous steroids, but not on a regular basis. But certainly conscious sedation, midazolam is very effective, very good. Some of you may be sedation trained nurses and have experience of that. And in the right hands, in the right setting with the right team and the correctly selected patient, it works really well. We don't tend to give polypharmacy, so we don't tend to give more than one drug in this country for sedation, whereas, if you go to the States, you might find that they're giving things like propofol and fentanyl and polypharmacy drugs. In this country, it's not common practice. So what is blood? What's in it? Dead simple. It carries nutrients around the body, it carries oxygen around the body, and it takes away waste as well. And you've got roughly 5 litres circulating in your average human. So this is quite a busy slide, but it just shows you that if you take that blood out of the body, this is what it's comprised of. So we've got the cellular components at the bottom there, and then the plasma. And you can see a lot of blood is water within that plasma. So proteins we've got at the top, you'll hear people talk about albumin, fibrinogen, things like that. They're the things that are important in the body. Water is a big component. And then the other solutes, so the waste products and nutrients. But then the bit at the bottom is really the nitty gritty. So the platelets, the blood cells that help us clot, the leukocytes, our white cells, and our erythrocytes, the red cells. And you can see that those cells are broken down further into other elements. Remember your physiology, which I'm sure is at the forefront of your mind. So the basic circulatory system of the body, the deoxygenated blood coming back to the heart, and it all being oxygenated through the lung system. And then you've got your systemic and pulmonary circuits. So that's just a bit of an overview. Key things that you need to be aware of really with cannulation. We can cannulate vessels, and they, as I said at the start, can be venous, so can be veins, or they can be arteries. If you cannulate an artery, it's obviously going to bleed more than a vein because it's under much more pressure. So everyone says, oh, it's spurting blood. If you clip a little artery, you may have seen it, occasionally we hit it in oral surgery. It will spurt a little bit, but generally the arteries that we come across in the oral cavity, certainly doing oral surgery, are not particularly significant. Having said that, the inferior alveolar artery, which runs quite close to the inferior alveolar nerve and vein in the mandible, if you clip that, you'll know about it, and it will bleed. So you will need to control that. But certainly veins can bleed as well. If you hit a big vein, for those of you that are nurses in max-fax units, you may have seen or had the unfortunate misfortune rather of seen significant vessels bleed if you've been in theatre or on the ward, for instance. A big vein, the jugular vein, will cause significant loss of blood fairly quickly. But that picture there just shows you all the veins and arteries in the body, and then we'll talk about which ones we want to use really. The other big difference between a vein and an artery is that veins have valves, so it prevents backflow if they work. Problems that you can get with veins, you will have probably all heard of a DVT, so a deep vein thrombosis. So that's really a vein in the leg where you get a clot forming, and that can be due to a variety of reasons: immobility, malignancy, sometimes the oral contraceptive pill. But if that clot then embolizes, it can embolize to the lungs, causing a pulmonary embolism, to the heart, cause myocardial infarction, a heart attack, or to the brain and cause a stroke. Other problems you can get is superficial thrombophlebitis, where you can see an inflamed small vein. Sometimes that's from trauma, usually resolves. Varicose veins you'll be aware of. So that's when those superficial veins swell up, the valve may be incompetent, and you get backflow. So the vein is full and it's distended. And then chronic venous insufficiency. You often see this in legs with really swollen ankles, and that can cause huge problems and lead to ulceration. So just a bit of an idea about what's going on. So these are the things I'm going to talk about: PRF and midazolam. And these are roles that I see no reason why, if you're trained appropriately, you can't take these roles on. So 2 areas that we commonly cannulate: the antecubital fossa in the arm there, commonly called the ACF, or the dorsum of the hand. And if you've been and had a cannula for an operation, or you've had blood taken, you will know that it can be a little bit uncomfortable, but certainly the ACF or the antecubital fossa is there in the arm. That's the safe triangle of cannulation. It's less vulnerable to vasoconstriction. So if you come in from the cold, you'll look at your veins on the back of your hand and they'll disappear. And they'll be really small and thready. Sometimes on just over the wrist, the flexor surface of the wrist, there's a little vein that we call the Houseman's vein. And that's what, certainly when we did house jobs in the good old days, that would be the vein we would rely on, because you often find that and there are no other veins present. Good sized veins in the antecubital fossa, often less painful and usually more successful. However, if you've got a high BMI, they can be difficult to find, and you need to be conscious of the anatomy in that area. So there is an artery, the brachial artery, and there is a nerve called the median nerve, which is medial. So that's towards the inside of the arm. And it's often less obvious if failed. So you might put your cannula in or put your needle in to take some blood and think, oh yeah, I'm in there. Even if there's no flashback or there's been a little bit of flashback, and actually you give some drugs and they have no effect. And you often don't realize until it's too late that those drugs are just building up in the soft tissues. And that can be a problem, because if it's something like midazolam, a sedative agent, they're still going to be absorbed at some point. Dorsum of the hand, you can see on that hand there, they're quite thready veins, quite small. So you need a small cannula to be effective here. Can be a little bit painful. And if you do kebab the vein, so you go through the top of it and then out the back of it, it bleeds, it will be really sore and swollen. So it's usually quite obvious if you've got that in the wrong place. But as I said earlier, they're vulnerable to vasoconstriction. So you often get people saying, oh, come and put your hands under some warm water, things like that. But it can be a little bit uncomfortable. The advantage of the back of the hand is if you've put a cannula in there and secured it, if the patient moves, it's unlikely to cause a problem. Whereas if it's in the arm, they bend their arm, it may come out or be disturbed. Problems with cannulation, so we can have venous spasm, hematoma, phlebitis, the extravascular cannula position, which I've just talked about, failed cannulation, interarterial cannulation, and then damage to local anatomy. So venospasm is basically when they get pain when you inject along the vein. And usually you can see that's because there's some irritation of the fluid, or you've given it too quickly. So you need to, with any of these problems, really take it out and resite your cannula. A hematoma you often see later on. So the patient might phone up the next day and so it's really sore and swollen. Or if you've got a patient who's anticoagulated, even on something like aspirin, 75 milligrams, they will get quite sore and swollen and it'll be red. So it'll be fairly obvious. But if that happens quite quickly and they've got a hematoma, you will not be able to give you drugs past that. So again, you need to resite that. Thrombosis, we talked a little bit about with the deep vein thrombosis. And again, that's obvious if it's in the back of the hand or the arm, because you get sudden swelling, quite painful, and it becomes quite red. Your platelets come to that area, start sticking, and that's when you get that thrombus forming. So again, you need to take that out and resite it. Phlebitis is pretty much inflammation, very painful, very sore, and patients will tell you fairly quickly that it's uncomfortable. So again, it needs to be recited. And this is what you will see. You can get quite pronounced swelling of the hand, actually. And these are all the kind of things you need to warn patients about. I know Len was talking about medical legal, and we live in such a litigious world these days that, you know, the consent forms that we use, patients often say, I'm not sure I want to have this done anymore, but we have to really warn them about everything that's going on. But if you get a sore, swollen hand like that and you've not warned them, they won't be too happy. And then extravasation, which is basically when you've gone through the vessel wall. So you've come through the top of the wall, gone out the back. And you'll know because you don't get this flashback, which I'll show you in a second. It's very sore and swollen, and then you get whatever you've injected through causing the swelling. So you need to resite that and use a completely different area, so preferably a different limb. But it's very sore when you put your Venflon in, your cannula in and flush it. It's very painful. And then nerve, tendon or ligament damage. This is, it's rare. If you've twanged a nerve with your needle, the patient will know about it. It's like an electric shock, so that you'll know instantly. It's really rare to get any symptoms like this or problems with cannulation, unless you really don't know what you're doing and you're just going in blind. You will see some people doing a blind attempt, and sometimes you can feel the vein with your finger, and you think it's deep and I'll go for that, but actually if you then twang a nerve, the patient will not be too happy again. So you need to be really cautious with this. And I think if you're a beginner or early experience, then just play safe. So how do we do this? On the left, you can see a tourniquet. We're now in this environment where everything's got to be super clean. So we use disposable tourniquets, believe it or not. If you haven't got one, you can use a glove, but you want to get your tourniquet on. And I usually lie my patients flat for cannulation, even if they look like they're fairly relaxed. But the last thing you want is a patient fainting, because it's just a nightmare, isn't it? So lie them flat, get their arm hanging over the side of the chair, get your tourniquet on, and get a nice big juicy vein that you can see. If you've got an assistant, then you can get somebody to hold the hand. Depending if you work in a trust or a practice, some trusts don't like assistants holding limbs and acting as a tourniquet. Then once you've found your vein, depending what you're doing, depends what kit you're going to use. So this is called a butterfly needle, which you may or may not have heard of. And the butterfly needle, basically, once you take that sheath off, I don't know if you can see my cursor, but when you take this off, you've just got a needle. And that needle remains in the vessel. So you cannulate your vessel, and then you will see blood shoot through all this tubing to here. And then on the end of this, we've got what's called a vacutainer system. So this enables you to take blood out under with the blood tubes, which is under vacuum, hence vacutainer, and it will then fill the tube up to the appropriate volume. You can also get butterflies that don't have the vacutainer on the end, but have a valve, so you can deliver drugs through this. Now, butterflies are often used for patients who are difficult to find veins on, because they're quite small and you get a little bit more dexterous with these. It is not recommended to use this to deliver drugs through. So if you're going to be sedating a patient and you're having an indwelling cannula, so it's going to stay for the procedure, then this is not what you want to leave in the vessel. It's not secure, and it's quite easy, if you've left that in and taped it on, for that metal needle to then cause problems within the vessel. So these are great for taking blood and job done. The other version of the vacutainer system is this, which if you've had any bloods taken, you may have seen, and this is a safety system. So once you flick off the pink sheath, you can then lock it back down, so you can resheath the needle. So this is again an indwelling metal needle, which you put into the vessel, and then you can see here we click the blood tubes onto the vacutainer system and then refill them. Now, there's an art to doing this, because once you've got this plastic tubing in with the needle, you need to keep it in that place. And you don't know, because you don't get what we call flashback, which I'll show you in a minute, if you're in. So this is really, for an experienced operator, think you're definitely in the vessel, click your tube on, and then you'll get blood in the tube or no blood. The problem is when you've put this vacutainer system into the vessel and you think, great, I'm in, and then you turn around to get your tubes, this hand needs to stay where it is, because if this hand moves, you either push it further in and the patient will scream, or you've pulled it out, turn around, tourniquet still on, and there's blood coming out of here. And it's not going to hose out, but it's messy. So you need to be prepared, have your tubes nearby, or have an assistant pass you the tubes. Once you've finished with your last tube, take the tube out, leave this in, undo the tourniquet, and then take the needle out and put some gauze on there to stop the bleeding. It's not recommended to then bend your arm, as people say, oh, quickly bend your arm. If you do that, you quite often cause some trauma to the vessel and you'll get bleeding and a hematoma. So keep the pressure on, keep the arm straight, and get that straight in the sharp spin. So again, it's technique sensitive, and it's just about preparation. A lot of the courses that we teach on, you use a plastic arm, which really isn't particularly great, because you can see where everybody else has put the needle in. And then this is what we call a venflon, or an indwelling cannula. And you can see here we've got, this is all plastic, I think, and I could be wrong here, this is made out of Teflon. When you pull this out, which is this component here, and this again is a safety system, so the nozzle on the end locks over the needle. Once you've put this into the vessel, you'll see blood come into this chamber. So as you advance this in, you can see the blood in the chamber. You hold the blue wings, or whatever color they are, depending on the size, hold that in situ and pull that out. Now, when you pull that out, blood will come through the system. So blood will start to pour out the end. So you then need to remove this cap and put that cap back on here. And then obviously this can go in the bin. And this is what we would recommend using for a delivery of drugs, particularly in sedation. So you can see here we've gone on the antecubital fossa. This is on the dorsum of the hand. And this is what we call a Veca fix, which is just a dressing that fixes it on. Once it's in and you're confident it's in, you want to flush it with some normal saline. And that just stops any clots forming in the tube here. And you should flush on a regular basis. So I tend to, when I've given some midazolam, I'll give a little flush before the midazolam, then give them midazolam, and then another flush to make sure that midazolam goes up into the system. Well, you don't want clots to form within this system, because if you do need to give any emergency drugs or reversal agents and it's clotted, then you've got no venous access. Some people advocate running a bag of fluid at the same time. If you do that, that's great, but just be conscious that if you run too much fluid through, the patient will need a wee at some point. So that can be a bit of an issue. So they are the three systems that we use really. But for things like platelet-rich fibrin, I would use the butterfly and midazolam we want to use an indwelling cannula. So this is the kind of kit you would get. And at our trust, we have a pack that's all pre-packed, all sterile. This is alcohol gel for cleaning the skin. And we've got our cannula. They come in different sizes and the colors relate to different sizes. So blue is the smallest, pink is the next one up, and that's probably sufficient for what you need for oral surgery. The really big chunky ones are green and grey, and that's what you would be using, if you're in hospital having either an operation or you need to give lots of fluids or give things like blood, then you would put some big cannulas in. But for the purposes of us, that's not what we're doing. So we're going to go for 24, 22 gauge. We have a cannulation document record, which is now gone electronic because of COVID. So this is all on an iPad now. And you can see where we record that patient's been consented, how many attempts have we had to put it in, when it was put in, that kind of thing. And if you're working on a ward, these are recorded and changed every so often. So quite often, so every 72 hours they get changed. And it tells you here why it's been removed, that kind of thing. So for short procedures, it's kind of helpful, but it's not particularly relevant. And then we've got a dressing, little yellow bag, and a bit of gauze. So here you can see we've chosen this vein here, and you can see once the tourniquet is on, and actually you can feel better than you can see on these. You can feel that bump there where the cannula's gone in. You can see that we've got flashback in this chamber, and as you hold this, so you push this down, and that blue, the end of the system will stop just before you've pierced the skin, and you withdraw the needle. Okay, so then all that's in that system is that plastic cannula. So actually, if you do need to move the limb, it will bend. Whereas if you left your butterfly in, that will not bend. So this is what we would use for delivery of drugs. Pull it out, and then that white cap goes on the end here. You might say, oh, why didn't you use that vessel there? Well, we could have done. Because the more median you come, the more anatomy gets in the way. The other thing we can do, so we give the drugs through that port there. So this lifts up and you secure your syringe onto the top, hold the ventral on, and then deliver your drugs. You can also deliver drugs through the end of that. So if I just go back, this white cap, when you take it off, obviously when you take it off, blood will come out. We can secure that to an intravenous infusion set, which will then go to a bag of, for example, fluid there. So that's where you might see patients in hospital, they're having fluid, or even antibiotics can deliver through this system, but you want to make sure that's secured. So the other thing I want to talk about is platelet-rich fibrin next. And PRF, you may have heard it called PRGF. There's loads of different systems on the market. The Tucron system is probably the most straightforward, and there's another system by BTI, and the BTI system is quite expensive, and in my experience, a bit of a faff, whereas the Tucron system is dead easy. So I'll talk to you about PRF, and if you recall that slide from earlier on, it's the platelet-rich fibrin. So it's the platelets here that we're going for, and within that, there's loads of different things that we want, and it's these bioactive molecules that we're going to touch on very briefly. So platelets, as you know, are really important in tissue regeneration and hemostasis. So they form that blood clot. They also secrete growth factors, and those growth factors ensure that the healing process occurs. And we know the more platelets, the better the regeneration of the area of surgery. And again, if we mix platelets with bone grafting material, we get enhanced angiogenesis. So that's healing and the formation of blood cells. There is evidence to show that platelet-rich fibrin in the surgical site reduces postoperative pain, and it also promotes healing, and it reduces infection. And the patients that have PRF placed use less over-the-counter analgesia than patients who didn't. So I've just put 3 papers up here as an example, but people have used it to look at the clinical and histologically of the evaluation of that socket really under the microscope, what's happening, using platelet-rich fibrin and piezo surgery after mandibular third molars. So that's a joint study. But then the interesting studies really are people who are at risk of dry socket. So as you'll be aware, there's not very much we can do to prevent or prophylactically deliver to prevent dry socket after an extraction at the time of surgery, other than advice, which is those people who are at risk of it. But we now know that actually if you put PRF in the socket, the chances of getting a dry socket are really low. And the other patients that this is really useful for, those patients on biologics, such as bisphosphonates or other biologics, sometimes methotrexate, or some of the weird and wonderful immunological therapies that patients are on. So we can reduce the risk of medication-related osteonecrosis of the jaws by using PRF. So this is me taking some PRF samples. This was on a study day, so that's why, and it's pre-COVID, so there's no mask and all that. So you can see I've got my tourniquet on, I've got my butterfly in, and I'm holding my butterfly with my left hand, so my non-dominant hand, whilst I use the tubes from the right hand. And you can see you've got flashback within that system. I'm holding that, and there's an art to this because you need to be able to hold this, be able to take the tube off and put another tube on. What we then do once we've got at least 2 tubes, and we need to balance the tubes in what's called a centrifuge. So this spins around, and it puts the heavier cells to the bottom, and at the top we get what has been nicknamed the snot clot. So I apologize, it's nearly lunchtime, but here you can see this nice clot at the top, and all the red cells have sunk to the bottom, and it's this clot that we want. So there we go. You can lift the clot up with some toothed forceps, and you cut off pretty much where those red cells are, because we don't want those cells. Then when you put the clot on this tray, and this tray is quite clever because they've not only made the grill into their brand, but it also allows any excess fluids to drip through this tray. The other thing you can see on the side here is 3 little holes. If you put this clot into one of these holes and then put this weight on, it almost makes it the size of a tooth socket. So very ingenious, very handy. You can flatten out that clot to form a membrane, and we can also mix that membrane with bone grafting material to form, when you pick this up, it's not quite an after 8 mint, but it's like a chocolatey wafer. It's obviously not chocolate, but it's a wafer that you can move around and manipulate into the sockets. So I've talked a little bit about when we would use this. When we take a tooth out, obviously we've got a socket and we've got a defect. Now this is an example of a patient that was referred to me who had a failed implant. And unfortunately it's anterior. I took the implant out and we've got a significant amount of bone defect here. So the question now is, if you just left that and let the body heal, you're not going to build it back up to where ideally you want it to place another implant, or even put a bridge or whatever over that. So implants come out. I'm going to graft that socket with some PRF and bone grafting material, and we can pack that into that entire defect. So with another sample of PRF, I then made a membrane. So I flattened that clot out, and that's the membrane. And then you can stitch the soft tissue back over, and we've filled that defect. Now, you will still get some resorption, but it means that the patient, we don't have to use anything in addition, like animal products. Here's another example. Patient referred to me with this upper 6 was root filled. The root filling had failed, and you can see in the antrum here, it's all hazy. So she had a cone beam CT scan. You can see the palatal root here on the top right is actually into the sinus, and we've got this inflammatory response around the bone and the lateral wall of the sinus. So I know if I take this tooth out that I'm going to create an oral antral communication. So rather than doing a buccal advancement flap or a palatal rotation flap, we can use PRF. So here's the tooth taken out. There's that dodgy palatal root. You can see straight into the sinus actually through here. And I've put PRF. So she had a really good clot, actually, massive clot, flatten it out, put it into the socket. So I usually put a clot deep and then use this as a membrane to close the defect. And that oral antral communication will heal really nicely. It means we've not lost any of the buccal sulcus and we've not lost any palatal tissue. So that's a really handy way that I use PRF these days. Now, for dental care professionals and particularly nurses, I see no reason why that can't be within your remit. So if you've got a really slick team, you could take the blood samples for the PRF, you could spin the PRF down and you get it on that tray ready for the surgeon to use. Certainly in our trust, we've got dental nurses who've been training in cannulation and venipuncture, so they can take bloods if we need bloods taken on outpatients. What we don't do, and I'm not sure about where we stand with this, is cannulation for delivery of drugs. But again, if you're trained and you're competent and you fulfill the competence package, I don't see any reason why you can't cannulate patients requiring sedation. And as Fiona touched on earlier, there are going to be courses coming up. And I'm a big believer in teamwork. And we run a lot of courses. We run oral surgery courses for dentists, implant courses for dentists, which is all well and good. But actually, at the end of the day, it's not just me doing the procedure. And, your nurse has got to be your best friend, and a good nurse is very proactive, can predict what's going to happen next and knows what's going to happen next, and is just, like gold dust really in making that procedure run so smoothly. So I'm a big believer in, if I'm training a dentist to place implants, that dentist needs to bring at least his or her nurse with them to be able to understand the whole procedure, the instruments we're going to use, at what stage we're going to use these instruments, and also things like post-operative instructions. So aside from assisting practically for oral surgery procedures and implant procedures, maybe taking bloods for PRF and cannulating, it's also really important, I think, for the next day for the post-op phone call or 48 hours down the line, that you train your nurse to deliver and triage any problems that come over the phone. So I think the role of the dental nurse is underestimated a lot of the time. And it's all very well for us in trust to say, yeah, okay, we can add these competencies on, but I think you need to be appropriately remunerated for those, and it needs to be further recognised. So, Fiona and I hopefully at some point will have up and running, whether it's an oral surgery course for nurses, and you come out with a qualification, or an implant assisting course for nurses. I think those things, this whole team ethos is absolutely critical to where we move on, because we're seeing more advanced procedures, certainly oral surgery and primary care, and the nursing staff and the team. It needs to be a team that work really well, and the nurses have extended skills. And incidentally, with all of that, I don't know at what stage you work at in primary care, but certainly in hospitals, the WHO surgical checklists, we need to be having team briefs at the start of the day, the start of the session, so everybody knows what's going on. You might be in a mixed practice where you've got an oral surgeon or somebody doing implants. The start of that morning, everybody needs to get together and say, X, Y, and Z's going on. This is the plan. We've got a tricky patient in who's got a complex medical history, or so-and-so is going to be doing some bloods in room 3 at this time. So just be aware of that, et cetera, et cetera. So we really need to be pushing this team approach. And on that note, the British Association of Oral Surgeons, which I'm a council member of, has a nurses membership category. And I'm going to say £20, but you might have to check that on the website. But have a look at baos.org.uk. At our annual conference, we always have a nurses study day, and I think that's going to get more and more integrated within the main conference. Sadly, due to COVID, that's obviously been postponed, but certainly we will be running online webinars, and I've pushed for that to be aimed at nurses as well. And as I said earlier, the Royal College of Surgeons of Edinburgh, it's in the pipeline, but nothing happens very quickly. But certainly Fiona and I are looking at courses and qualifications for dental nurses in both oral surgery and implantology. So I hope that's giving you an idea of where we use how cannulation can be used in oral surgery.